Good afternoon. My name is Micheline Cormier, and I will present my research proposal for a comparison of low, moderate, and high carbohydrate diet on insulin resistance in adult women with grade 1 obesity. Insulin resistance happens when the body cannot use insulin properly. It is the main driver in chronic diseases like type 2 diabetes, heart disease, and type 3 diabetes or Alzheimer's. These conditions affect the quality of life of nearly half of Americans, and the numbers continue to grow, making insulin resistance a current public health concern. While the etiology of insulin resistance is unknown, low carbohydrate diets improve insulin sensitivity, meaning they might play a key role in the prevention of chronic diseases. However, low carbohydrate diets and weight loss are observed together, which complicates the situation because losing weight independently corrects insulin resistance. Recent data shows that carbohydrate intolerance might play a key role in insulin resistance, though the data is limited. As a result, this proposal addresses the research question: do eucaloric, low, moderate, and high carbohydrate diets have different effects on insulin resistance in women aged 19 to 50 years old with grade 1 obesity? This will be answered by comparing the effects of the three diets on outcomes commonly used to study insulin resistance, such as BMI, percent body fat, waist to height ratio, fasting insulin, and HOMA-IR, which measures the degree of insulin resistance in the body. A key definition here is eucaloric, meaning the diets will keep weight stable throughout the study. For example, as carbohydrate amounts decrease in the diet, calories from fat will increase, keeping energy constant. This is important because removing weight loss from the equation will support a causal relationship between carbohydrate intolerance and insulin resistance in the sample population. Insulin is the key that unlocks the cell. When the system is defective, the levels rise and resistance sets in. Currently, a third of Americans suffer from insulin resistance. Additionally, 70% of obese women are insulin resistant. A scholarly review indicates that while insulin resistance is corrected by low carbohydrate diets, the benefit is often attributed to the weight loss. Additionally, these studies show a larger improvement of insulin resistance in women compared to men. However, the carbohydrate insulin model of obesity recently suggested that the source of the calorie is more important than the calorie itself. If this is true, adjusting carbohydrate intake while keeping energy stable could show improvements in insulin resistance markers. To test this theory, Hyde et al. Recently conducted a randomized control trial on 16 men and women. The findings indicated that following a low carbohydrate diet for 4 weeks was effective at reversing metabolic syndrome, including insulin resistance, independently of weight loss. Accordingly, my research proposal attempts to replicate similar findings advanced in 2019 by Hyde et al., applying their research protocol to obese adult women and honing in on insulin resistance. Since the study involves human subjects, it is designed to comply with the principles of the Belmont Report. Accordingly, the low risk level will be addressed, informed consent will be received, personally identifiable data will not be retained, and all collected information will be subject to HIPAA regulations. Upon approval from the IRB of MedStar Health System, the methodology process will begin with the recruitment strategy. The study will take place in Washington, D.C. 18 participants meeting the inclusion criteria will be recruited from the outpatient services of MedStar. This will be done through flyers, listservs, and word of mouth. It is important to note that this sample reflects a medium effect size, gives the study 80% power, and accounts for attrition rates of similar studies. It will be a 16-week 3x3 crossover design. Diets will be randomized to reduce bias in datasets. A 2-week lead-in diet will provide baseline energy needs. Then each diet will be followed for 4 weeks with a 2-week washout period in between treatments to reduce crossover effect. All food will be provided to ensure consistent energy intake. This design is key because it helps to reduce the sample size needed for statistical significance. Baseline and post-treatment measurements will be collected by medical professionals. BMI, percent body fat, and waist to height ratio will ensure the eucaloric value of the diet, while HOMA-IR will assess changes in insulin resistance. At the heart of the study is the statistical analysis that will help to answer the research question. First, descriptive statistics will ensure that all test assumptions are met. Then, the repeated measures ANOVA will compare the differences among and between the datasets to determine statistical difference. If a statistical difference is found between the means, a post-hoc comparison will be performed using the Bonferroni correction to compare mean to each other mean. This will set the p-value to less or equal 0.001 in order to reduce the risk of a type 1 error since we are comparing many outcome variables. It will also identify where the difference in means is found and enable us to accept or reject the null hypothesis, thus answering the research question. This study has several strengths. This topic is a current public health concern at the core of chronic diseases. Significant findings could help create new clinical protocols in diabetes, obesity, and cardiovascular management. It also adds to the current body of knowledge by strengthening the causality between carbohydrate intolerance and insulin resistance. This could open the gate to new areas of research, namely in nutrigenomics and personalized medicine. Lastly, the experimental process is the gold standard to determine causal relationship, and this crossover design offers robustness to the dataset. It makes it more statistically efficient to conduct a solid study, limits potential confounding treatment data, reduces bias in datasets, and reduces variability between participants as subjects act as their own control. The study has limitations, potential carryover effect and diet order bias. However, these were minimized by a 2-week washout period between treatments and a balanced randomization of diet order. The length, the sample size, and the highly structured environment are other limitations that should be considered. A larger sample size might yield different results. The short-term results might be difficult to sustain for longer periods of time, and the findings might be difficult to reproduce in free living conditions. Healthcare professionals need evidence-based guidelines to help them improve patient care. This dataset will produce building blocks that could contribute to clinical care maps, standardizing nutritional and medical practices in diabetes, cardiovascular, and obesity management. The significant findings might also elicit additional well-designed studies using larger sample sizes, focusing on longer periods of time, and using conditions of free living. This could also identify barriers that humans face with long-term behavioral change and success, and the need for a multidisciplinary approach in the treatment. Lastly, substantive findings on the causality between carbohydrate intolerance and insulin resistance might be used in reformulation of the DGAs, making them more effective in the control of obesity. This concludes my presentation. I welcome your feedback and thank you very much for listening.